All right, hello, and thank you for joining me today. We're going to be talking about a novel treatment for pain, thyroid, and autoimmune disorders. And this is our monthly educational seminar that we're doing at Moses Lake Professional Pharmacy. We started doing that in the spring. We've done a couple on hormones. You can, if you want a copy of those, please let us know and we can send you the link. It's on YouTube. Go to our Moses Lake Professional Pharmacy YouTube site and you can find those videos. So disclosure, obviously, I am a compounding pharmacist and I own Moses Lake Professional Pharmacy. Compounding medications, which we're going to be talking about today, are not FDA approved. So here, if some of you have already probably seen the objectives, but we're going to learn the history of the novel treatments and of the novel treatments for the things we're talking about, how they're used to treat pain, how they're used to treat thyroid disorders, actually hypo and hyperthyroid. Learn how these alternative treatments can be used to treat other autoimmune diseases, because some thyroid is actually caused by autoimmune disease. And we're going to learn about the mechanism of action and how to dose the novel treatment. So the novel treatment is low-dose naltrexone. So why do I say low-dose naltrexone? Because naltrexone has been around for years to be used for other things. We'll get into that a little bit later, but at a 50 milligram dose. So we're talking about anything usually less than 10 milligrams is low-dose naltrexone. So nothing new, just some maybe new treatments modalities that we've found that it works for. It was synthesized in 1963. When we're talking about pain, within a certain dosage window, it has a paradoxical effect to treat pain. It, in theory, shouldn't work to treat pain, right? Because it is an opioid blocker like naloxone. It is absorbed better orally and has a longer half-life than naloxone. So that's why you only have to take it once a day. It has a paradoxical effect. So instead of it helps to downregulate the opioid receptors to treat pain. We'll get into the details a little bit of that later. It can be used as monotherapy without opioids. It's very important to understand that when you start it for pain, that the patient has to be off opioids, and usually with most of them are okay within, they have to be off it for like 2 weeks. Methadone, because it has a longer half-life, has to be over a month. So there has been some experience with ultra low dose, like 0.4 milligrams used, and even 0.04, I think, if I remember reading some of the literature, in conjunction with opioids to help for pain. I don't suggest that, because if you do use any kind of opioid blocker, you can, along with opioids, you can have side effects, so which would be withdrawal symptoms. So what is the history? It was actually approved in 1984 to treat opioid addiction and alcohol withdrawal at 50 to 100 milligrams. So that's why we're talking about the low dose today. We're not talking about, the higher dose. Usually we talk about 1/10 the dose. The most common dose of low dose naltrexone is 4.5 milligrams. And for whatever reason, we're going to talk of the proposed mechanism of actions of why it has an anti-inflammatory effect at a lower dose, but at the higher doses, it doesn't have that anti-inflammatory. So it is a competitive antagonist at the opioid receptor, blocks opioid receptors. It works on immunomodulation via the opioid receptor. We'll talk about some of the details of that too. That's why it can work for some autoimmune diseases. So this is what the analogy I like to give. So when we give opioids, the patient gets tolerant, and you got to give more, and you got to give more in order for the patient to receive effect. So what actually low-dose naltrexone does is it makes those receptors downregulate. So once they've been clear of opioids and you put them on low-dose naltrexone, the opioid receptors start downregulating, so they don't need as much. They wouldn't need as much pain medication or any pain medication at all, because there's not as many receptors there to fill it up. The glia cells, when activated, cause an inflammatory response in the brain, cytokines, and it can contribute to pain. So LDN, low-dose naltrexone, may be a glia cell modulator and works as an anti-inflammatory independent of the opioid receptor. That's speculation about what the theories are postulated of why it could work. So LDN in chronic pain. Fibromyalgia does not commonly respond to typical anti-inflammatories. So your typical NSAIDs, it's not going to usually work for, yet there may be an inflammatory component, maybe an autoimmune component too. So that might be why LDN works in chronic pain. But a double-blind study showed that 57% of patients exhibited 1/3 less pain with 4.5 milligrams of LDN nightly. So I already talked a little bit about the proposed mechanism of action. Works on the glia cells, and if you look at how, like, naltrexone is the stereoisomer instead of levonaltrexone, or the racemic mixture, which is low dose naltrexone is normally the levo and the dextro, but the dextro naltrexone has no effect on the opioid receptor, yet it possesses anti-inflammatory properties. So there's something more going on than just the opioid receptor. We do know that. And if you look at ESR, patients with elevated ESR tend to respond, which is an inflammatory response, which tend to respond better to LDN. But realize this, LDN will not lower the ESR, but those patients typically do respond better. So other mechanisms, I'm kind of just really reiterating these, but small and transient blockage can cause upregulation of endogenous opioids and downregulation of opioid receptors. So when you have your endogenous opioids, you also get endorphins, and then you have less of the receptor, so you don't need as much to respond to pain. So opioid rebound effect, I just put that in there. It can enhance endogenous analgesia. So the dosing. So I think we're ultra conservative when it comes to dosing LDN. I think a lot of the early reports was there were some side effects if you started with a 4.5 milligram right offhand. That's where most patients end up, is at 4.5 milligram. The most common side effect is vivid dreams. I don't see that very often, but that would be the most common side effect, and you just go back down to the lower dose beforehand. So I think, sometimes we're ultra careful when we're titrating the dose, but we can start out with 0.5 milligram QHS at night, and we increase by 0.5 milligrams every week until they're up to 4.5 milligrams. Most patients end up at 4.5 milligrams. Now realize this, a lot of the side effects that early on in some of the studies that were complained of with low-dose naltrexone, like anxiety and nausea, are actually side effects of withdrawal. So it's not necessarily a side effect from the low-dose naltrexone to speak as much as it is a side effect from opioid withdrawal. So, be cautious of that and be aware of that. So one thing that's important is that to work the best for the autoimmune diseases and for the pain, it can't be a sustained release capsule. It must be an immediate release capsule. Most common dose, 4.5 milligrams. The side effect of insomnia or vivid dreams, you just use a lower dose. So why low dose? Because complete blockage would have a negative outcome on chronic pain, possibly at a higher dose. I mean, we don't know, but obviously, it makes some sense. A paradoxical hyperanalgesia effect of low dose morphine. So there's been studies to show that super low doses of morphine can cause a paradoxical effect of hyperanalgesia, like a lot of pain. So low dose naltrexone does just the opposite of that. So just realize too that when we're talking about, patients might get confused sometimes when they do an internet search and they look up naltrexone and they look that it's used for alcohol or substance abuse treatment, but that's at higher doses. Please educate your patients about that. We try to educate all of our patients about that so they're not surprised when they go do an internet search. So yeah, the 50 milligram is commercially available, approved to treat substance abuse. Of course, Big Pharma knows how popular and how well low-dose naltrexone is working, so they're in clinical trials right now to try to get a drug approved on the market. Before compounding pharmacies were doing this, what was being done was a lot of providers or doctors were asking their patients to take the 50 milligram tablet and divide it up into 10 doses. There's obviously some problems with that as far as accuracy of dosing, not very convenient. And it's harder to titrate dosage. So it's much better to get it compounded by a pharmacy that knows how to compound a capsule. It's not super expensive either. That's the beautiful thing. Anywhere from $30 to $40 a month, which is much, much less than a lot of other treatments for chronic pain. The most beautiful thing about low-dose naltrexone, it has a very, very good side effect profile. It doesn't cause ulcers. It doesn't cause renal insufficiency like NSAIDs. No heart attacks or clotting factors like seen with NSAIDs. No withdrawal symptoms, as long as they're off their opioids. Like I said, the major side effect from it is vivid dreams or insomnia, and that's still pretty uncommon. And a lot of times that is dose related, and they can build up a tolerance to that, so it does get better over time. So if you look at some of those other side effects, headaches, tachycardia, anxiety, that can be from opioid withdrawal too. So realize it's important to ask your patients about those side effects and make sure that they've been completely washed out of their opioids before they start the treatment. So no liver toxicity, even at the higher doses, no abuse potential. You don't build up a tolerance to it. You don't get addicted to it. The way we're treating chronic pain now with a lot of opioids and the way it's in the news big time right now, that's very important. There's no abuse potential. So not every patient is obviously going to be low dose naltrexone when they're in chronic pain and they're on opioids. If you want to try to get them off, it's definitely a conversation you definitely have to have with each individual patient, because some patients unfortunately are not motivated to get off their opioids. Low dose naltrexone and thyroid. So Graves' disease, antibodies stimulate the thyroid receptor and it results in hyperthyroid. Pretty rare. Hashimoto's is less rare and diagnosed quite often nowadays. It seems like, at least we see a lot of those patients. It's kind of just the opposite, where antibodies destroy the thyroid gland, resulting in hypothyroid. So LDN somehow is shown to modulate the immune system and reduce the abnormal production of antibodies. So whether the antibodies are stimulating the thyroid receptor or destroying the thyroid receptor, it can work either way. I know that doesn't make a lot of sense pharmacologically speaking necessarily, but that's what we think is going on, because there are patients that respond to it that have Graves' disease and or Hashimoto's. And not just Hashimoto's, but so much thyroid, even if they don't have Hashimoto's diagnosis, so much thyroid in our experience has some autoimmune component. So I see a lot of practitioners just start LDN on patients that they're just not responding super well to the thyroid hormone alone. Diagnosis and monitoring thyroid function. I could talk about this for 8 hours. I really have a passion on hormones and thyroid. There's a great video on the Mosaic Professional Pharmacy's YouTube site if you would like more information on thyroid monitoring. And I did a specific presentation on thyroid. But one thing that's important is that, it's more than just TSH. TSH is a pituitary hormone. It's not a thyroid hormone. When it comes to monitoring thyroid function, it makes about as much sense as the way we monitor, testosterone therapy for a man or a woman. We don't check necessarily LH or FSH when we're monitoring actual therapy. We check testosterone levels. So I believe thyroid should be the same. I think you need a free T3 level and a free T4. Remember, free T3 is much more active than free T4, and T4, levothyroxine. Free T3 is liothyronine. Levothyroxine has to be converted into T3 in order to be active. So that's why it's so important to check free T3 levels, because there might be certain patients that are on levothyroxine, they don't feel better, and it's because they're not converting levothyroxine to liothyronine, T4 to T3. So, and they're both really simple hormones. T4 is L-tyrosine and 4 iodines. T3 is tyrosine and 3 iodines. But that conversion can be affected by many different things. Too high of estrogen levels, for one, birth control pills, alcohol, stress, lack of selenium can decrease that conversion. Just aging in general can decrease that conversion. So T3 is very, very important. Don't forget about T3 when you're checking thyroid function. LDN and depression. LDN increases the release of endorphins and dynorphins. Obviously, that's going to make us feel good. It's what endorphins do. So endorphins are released in response to exercise, orgasm, food. So if LDN can do that, obviously can make us feel good. So also on thyroid, think about it. If LDN helps for thyroid function, it can definitely help for depression also, because if your thyroid is not optimal, you might have depression. So it's kind of like the opposite of people coming off opioids. If people are coming off opioids, they get depressed. So think about if LDN does the opposite of that. So when people have an endorphin deficiency, they get extremely sensitive. They're extremely emotional. They have physical pain. So a trial of LDN would be worthwhile possibly for them, especially if they've tried many other things. How does it work? We don't really know, but here's some theories. So blocking the kappa receptor may be beneficial in treating depression and anxiety, which is sensitive to dynorphins. Most medications also activate the mu receptor, and the mu receptor is the one that makes people feel high, gives them euphoria, and thus thus addiction. So that's what's nice about LDN is it only works on the kappa receptor of the opioid. So when I talk about LDN, it's not really completely in non-traditional medicine for sure. I mean, Contrave, which is indicated for weight loss, it has LDN in it. It's at 16 milligrams, so it's not really the low dose as far as 10 milligrams or under, but it's still less than the 50 milligrams. And it also has buprenorphine in it. So when you look at that for weight loss, you also you can think about, how it might work for depression too. So there's probably some overlap there. When endorphins increase, dopamine is released, and that's what really makes us feel good. So that might be one of the mechanisms of actions for LDN to treat depression. This is one thing we're seeing in common practice nowadays, even in traditional practice. We're seeing low-dose naltrexone in rheumatoid arthritis. Many mainstream rheumatologists are prescribing it now, and we don't really know why it works, but it's being prescribed a lot. Is it because of the glia cells and the anti-inflammatory effect? We don't know, but like I said, it's really in the literature a lot nowadays. A lot of mainstream rheumatologists are prescribing it. And rheumatoid arthritis is, obviously can have an autoimmune portion, and there is inflammation, but also an autoimmune portion. So, and we talked about low-dose naltrexone and its effect on autoimmune diseases. What are some other things that it might work for in autoimmune diseases? Fibromyalgia, lupus, multiple sclerosis, inflammatory bowel disease. What's interesting about all these, I wouldn't say all, but most of those I just discussed, is there's also an inflammatory component. So does it work because of the inflammation, or how else does it work because of the anti-inflammatory effect, or how else does it work in the body on the immune system? We're not really sure. But I can tell you the great thing about low-dose naltrexone is that it just doesn't have a lot of side effects, and it's always, I think, worth a trial because it's in certain things that are just non-responsive to traditional treatments, especially because it has very low side effects and it's really inexpensive. When I get a call for patients that are not responding to certain other treatments, and recommend the dosing. So this is a great book. It almost makes LDN too good to be true. That's why I don't like to oversell the book, but it talks about the diseases we talk about and a lot more. LDN is getting a lot more popular, gaining a lot of steam. We're seeing a lot more of it in the pharmacy, even from traditional practices, not just alternative practices. Great website too, ldnresearchtrust.org. It's they have an annual conference too. Obviously, with COVID, they've not had a conference this year, but there's an annual worldwide conference, and it's very well attended. That concludes my presentation. I was leaving room for questions, so if anybody has questions, please email me there, Shawn Needham at MLRX.com, or my cell phone 509-750-6912. Stay tuned for our monthly presentation. Next month, we'll be talking about men's testosterone, how to diagnose, and how to monitor the therapy and make sure labs are optimal. So thank you for tuning in today. We appreciate it. And if you have any questions, you've got my contact information. Thank you so much.